Welcome back to another fabulous episode of the Healthcare Trailblazers podcast. Excited to be sitting here with somebody that I consider a friend. I've been talking to Dana for a bunch of months now, back and forth. We've been trying to make this happen, and we finally can. So I'm excited. Ladies and gentlemen, Dana Strauss. Dana, thank you so much for being here.
Thank you for having me.
For those that are unaware, first of all, go follow Dana on LinkedIn. We'll start with that because she puts out a lot of phenomenal content, which we'll get into in a second. But current title is Senior Director of Government Affairs at CVS Health. You've had a lot of interesting stops in your background. We don't have to go all to the first one, but maybe let's talk about right before what were you doing before you came in to CVS, and then we can get into CVS and your work.
Yeah, I've had a lot of change in the past 4 years. I was a treating clinician for 15 years, and then I worked in the clinical liaison space, and then moved into helping to build a population health department and transitions program within a health system, and managing those programs. And so I really cut my teeth right within the health system after being a clinician, which, being in the policy space now is kind of a different and relatively unusual angle from what I've seen. I spent some time at a great startup called Integrated Care Solutions, partnering with organizations who are been helping them to take risk and be successful in value-based care, and then was fortunate to come to Signify. And I came in client success, and then was asked to join the government affairs team to be a public policy expert, really in value-based care. And so I've had the privilege of working to help support the Medicare Shared Savings Program. When I originally came on, it was also for BPCI Advanced. And now, since CVS acquired Signify, I am working on value-based care policy for healthcare delivery. So CVS has a bunch of different parts of their organization, and I'm working really on the part that focuses on healthcare delivery in value-based care programs.
Awesome. So, let's jump right into to value-based care. Obviously, central to the podcast, and we have so many interesting angles and topics about it. But, the question still remains, will value-based care actually prove itself? And so let's start with a question that I like asking people. What is your definition of value-based care? What does value-based care mean to you in a short sentence?
I think it's hard to separate value-based care from accountable care. But value-based care, in my mind, looks at and focuses on the quality and cost of care and providing care at the right time in the right place. And I think what we lose sometimes in the definitions that we just read online are that it's a focus on evidence-based practice or evidence-informed care, right? So making the right decisions for the right reasons and changing the incentives, shifting them away, hopefully, in the most successful programs, away from delivering volume of care and really looking at providing whatever care it is that's best for an individual on an individual basis.
Yeah. And when we talk about some of those models, I guess let's start with generally. Are you hopeful? Well, some people say that it still hasn't proven to actually be effective on the bottom line. Is that your opinion?
No, it's definitely not my opinion. Some of what we hear and what we read about and what's studied is you have to take into consideration that this work is still very new, right? We think, value-based care has been around forever. It really hasn't. I mean, this is, generally speaking, we knew that there were things that had to change, but it really wasn't until the Affordable Care Act and, the first accountable care organizations. So it's really been a decade. And anybody in healthcare knows that changing healthcare is like moving the Titanic. We absolutely know that it very much depends on the buy-in of the providers, the buy-in of those that are managing the programs, the decisions that are made about those programs that will lead to success or just a little bit of success or outright failure. And by understanding really the difference between an organization that's prepared to take on risk and prepared to and interested in moving to value, providers in that organization willing to move to value, we can, generally predict who can be successful. I don't mean, by the data, just looking at that, but when we see variability in the success of value-based care, we have to take into consideration that all kinds of organizations are participating, and they're all at different stages of buy-in and experience and readiness. And so we've just begun, right? This first 10 years is just beginning. We are going to see the biggest movement happen in the next 5 to 10 years would be my prediction.
Okay, so I totally agree with you, but that actually brings me to my next question, which is around one of the biggest, I think, challenges that I see, which is the fact that, it's very interesting because in some areas of government, the biggest problem is that there are no sunsetting, kind of clauses, and that they just run forever and budgets just run forever. And in other areas of government, and I think predominantly healthcare, we possibly have the opposite issue where not enough time is given to actually realize, achieve a lot of these objectives. And to compound that is the fact that the administration changes at maximum every 8 years, but sometimes every 4 years, and that has downstream effects on policy and downstream effects on what models are made available and how reimbursements are. So, what are your thoughts around how the administration changes can affect the ability to ever see some sort of, stick to one path and try to prove efficacy in one lane?
Mm-hmm. So when it comes to the Innovation Center, this is, again, relatively new. And when a new administration comes in, even in the second term of an administration, there's going to be turnover of leadership, and there'll be philosophical differences and areas of concentration in one area or another. And, depending on who's appointed to what positions, we're going to see some variability. But what we enjoy in value-based care is overall, generally bipartisan support. That doesn't mean that there isn't, always education to be done, because the topic is healthcare is complex, but value-based care, healthcare is even more complex. So there's education to do on the Hill always, right? That'll be ongoing. But overall, the Innovation Center is still a very important and popular place for us to test out new methodologies. And the Innovation Center itself is, looking at how they evaluate models. They're looking at how they put out models. They're looking at just, generally what needs to change on a move forward basis, redefining their quality strategy, reevaluating how they evaluate models. And I say all that to say, administration to administration, we'll see areas of focus more in one way or another, but both parties and HHS, CMS, they want to see consistency, right? It's good for value-based care to see consistency. So some of it's probably, fear, political talk, but, I would hope and expect that we'll just continue to see the Innovation Center push forward, continue to iterate and improve upon how they design models, how they evaluate models. And I would expect to see, no matter who's in office next, that we'll continue to see a lot of interesting and good innovation coming from the Innovation Center.
Yeah, and I definitely hope so too. So what are some going kind of back to the basics? What are some basic tenets, basic programs, basic principles that you think an organization has to employ in order to be successful at taking on any kind of risk?
More than anything, you need provider buy-in, in my experience. So you need those who are actually delivering the care directly to patients to have both the flexibility in their operations, especially right in primary care, where needing to move to team-based care. You need to be able to provide that more connected care, that advanced team-based care. Those who can do that will just have an easier job being successful. What really changes in value-based care is how we, I have this little phrase I use, communicate and connect. It's a difference between fee-for-service and value-based care is really about having the time and the focus on connecting with patients, on building trust, on working together in teams, which we know is best for patients. Right. So those who embrace that, who are able to and willing and interested in entering models where they have that flexibility and can work together and build out teams, they're the ones I think have the greatest chance of being successful and really is critically important.
Yeah. I mean, I couldn't agree with you more. Something I think an additional element that I find fascinating that I don't think is talked about enough is, of course, we have to get the physicians on board. You're spot on. But I think that at the end of the day, nothing works unless you actually get the patient on board, right? And I know it's such a given that it's almost overlooked sometimes. But my issue is that in the reimbursement models, it's the incentive structure has created this dynamic where it almost feels like it's my doctor's problem. My health is my doctor's problem. And if I'm healthy, they get rewarded. And if I'm sick, they get dinged in value-based care, right? And it's like, you've got like, chronic care management, whatever, these different programs where the dynamic is like, hey, can you please sit with me on the phone for 20 minutes a month and talk about your health? And it's like, okay, maybe, how is there any focus from your perspective? Is there any focus being put on really filling that gap and figuring out how to pull the patient into the conversation in a meaningful way?
Yeah, and you're right. I mean, we should never talk about provider engagement without talking about patient engagement. And it doesn't mean provider engagement is more important in care. It means, and I highlighted that because it's the incentives that the provider has financially that will just naturally, like in all business, right, in anything, are going to determine how and what care they're able to deliver. And we have to think of patient engagement as just a care delivery strategy. We don't get the outcomes that we want to see for our patients unless we can engage them. So it's more a matter of fee for service is absolutely anti-individualized, patient engagement focused team-based care. And, at the extreme, especially at the more extreme where providers are taking on full risk, those models are inherently designed so that patients can be engaged as fully as possible, understand their conditions, understand how to monitor them, understand how to reach out for help. And so you bring, like, those are probably number 1 and 2, provider incentives and buy-in, and then those incentives and buy-in creating an environment where patient engagement is now a priority and they're being incentivized to do it.
Yeah.
Right. As a team.
Yep.
Yeah.
When you speak about patient engagement and from your lens, from a policy perspective, I have to ask, what would be the path to get the biggest issue with a lot of these preventive care, programs like chronic care management, like transitional care management, like whatever. There's a copay that these patients are charged. And not only are the patients charged a copay, but the doctor is not allowed to waive the copay. Then they start getting into Stark laws and anti-kickback laws, stuff like that. So it's kind of like, damned if you do, damned if you don't. And from our perspective, from our experience, literally that stops literally 80% of patients from partaking in these programs. And what drives me crazy about it is that it's a preventive care program, which means that the whole purpose of the program is to save CMS money. Why would you stop 80% of patients from being allowed? Now, I know a bunch of people are talking about this, but from a policy perspective, from your lens, what is your advice, or how do we get this done? How do we get rid of the copay for preventive care?
Right. And it's a great question and been the focus of many conversations across stakeholders for many years. I guess I could say a couple things. Their innovation center models have dabbled in this a bit. And in one of the newer models, don't quote me, maybe primary care flex, there is a potential waiving of copays. And so the more innovative, more advanced models are trying to, within the flexibilities that the Innovation Center feels they have for different models, they're trying to weave that in to varying degrees. And really, they have to, over the course of testing these models, they have to prove that they're valuable, that they do what they say we think they're going to do. We can, hypothetically say more care management will lead to better outcomes. But that has to be tested and rigorously. And this goes into, what I was saying at the beginning. The Innovation Center is openly talking about reevaluating how they evaluate models so that they can take components and once they're successful, move them, and success can look like quality also, move them into statutory permanent programs. So yes, it's, I think there's across the board, a lot of stakeholders believe that waiving copays for chronic care management is something that we should at least be doing in higher risk or higher accountability models. I think the question just becomes is we think about paying primary care differently in the long term, as we think about paying them differently, does that just become no longer part of the conversation because we we don't believe that the basic primary care services should have copays overall. Right now, as you guys know, many listeners, it's the preventative services listed on CMS's website that they update. Those are the services without copays. They add to that. One of the ideas is, well, just if we add the chronic care management codes to the preventative services, that would be another way to get rid of copays for those services. So there's different ways to do it. Congress can do it, and CMS and through the Innovation Center can do it. But again, we're on this path, where there's a solution somewhere further along the path. And right now we're dabbling in it to see what works and if our hypotheses about it are correct. And does it take a certain level of risk in order to have that removing that copay be beneficial in the long run, right?
Yeah. Well, I'm super happy to hear that it's such a big conversation. I know it's a conversation, but and in all fairness, I am aware that there are, like, even in the ACO REACH program, I believe there are ways of getting rid of the copay, but it becomes just a logistical. Like, I know from practical experience, it becomes a logistical nightmare. It's like, okay, well, great, but how do you actually get these dollars into the hands of the patients only to pay for the copay and not for the, because it's not actually a wave, it's like a reimbursement, and it starts getting really sticky. So I think what you mentioned is a lot more practical. Either put it in the preventive suite and make it just, there is no copay period. Yeah, pretty much. That's really the only path. Talking about regulation and kind of policy, let's talk about AI for a second, because everyone has to talk about AI. But would love to get your perspective on where's this going to go from a policy perspective. Is policy going to be beneficial for AI and make it safer? Is it going to completely tamp down innovation and strangle startups and strangle innovation? Is the government even equipped to be smart about and about kind of regulation in AI? Are they listening to the right people? It's a very young industry, not just in age, but it's just very brand new, and there's kind of it's not something that I think your typical congressman or congresswoman or anyone in healthcare has necessarily experienced it. So give us the landscape of regulation around AI in healthcare.
Well, first to say, I don't focus on AI regulations, and that's not, I would say, my area of expertise. I guess to say generally, and at a 30,000 foot view, there's a lot to tease through before we should be making some of the decisions about how AI will be regulated. It depends what kind of AI we're talking about. Are we talking about the AI we've been using for years and not calling AI, or machine learning, or is it generative AI? So there's so many use cases where it just makes everything easier and safer. And there's other potential use cases that I think need to be, just thought about differently. So I'm not going to opine on what they should or should not do around artificial intelligence, except to say I think we've got a long road ahead, and a lot of states are moving on it sooner. And that's part of what we're watching that's interesting, if interesting is the right word. If states are acting on it faster and the federal government isn't, what is that going to mean? What are going to be the repercussions? So I would say I'm watching just like everyone else is. Well,
I think you're being humble. I think even in your short 30,000 foot view answer, I think that was more coherent than a lot of things that I've heard. And just what you said about focusing on the use case and even understanding the differentiation between the various different use cases, I think is very, very prudent, very smart, and not something that I've seen talked about a lot. It's just like, if this touches AI, then we have to do XYZ. And you're absolutely correct. There are so many different use cases. Where does the AI sit? Is it, is this getting rid of an administrative function that's just horrible? And does it sit behind people? Does it sit in front of the people? Like, where is it? Who is it affecting? Is it patient facing? Is it, is it making medical decisions? I mean, you're absolutely correct. So, but
I would say one other thing, Mendel, just where AI can improve safety and quality of care, it is potentially some of the most important and most interesting to watch, right? There's things that artificial intelligence can and should be able to do that can make care safer and more standardized, right? Where it should be standardized. There's individual care, and we talk about individualized care in one way, but patient safety is another aspect of care that maybe we sometimes don't talk about as much as we should. Maybe we don't think of it as aligning directly with value-based care, but it does. So where artificial intelligence can make care safer in a whole variety of settings, that's really exciting. And we should, this is a positive, right? Overall, this is a really positive thing. It's just, what are the things that we're not thinking about that those who have to help keep us safe by, watching over its development more carefully than we are? I mean, individually, the individual we are, that's where we're going to have to watch things unfold.
Yeah. I agree.
Yeah.
So are we allowed to talk about your super secret, top secret, special, unique, exclusive newsletter?
My little newsletter that I write, called Timeless Autonomy. This has nothing to do with my job. This is somewhat of a hobby, I'd say. And I like to write about topics. I would say it's still being refined. So at first I was really putting out kind of full blogs with kind of deep dives on different topics. The goal really of the newsletter / blog is to help educate clinicians and others that are working in healthcare about value-based care. And not just value-based care, but healthcare innovation. So I kind of lump value-based care into that space, but healthcare innovation, home-based care innovation, there are so many aspects of healthcare that what happens, I see, having worked not too common for a clinician to work in just about every part of healthcare, to also have a lens into healthcare delivery policy and regulations. There are not enough clinicians with deep knowledge or even significant knowledge about how the business works, even within their own silo. So understanding, right, the incentives of their site of care, and then understanding how value-based care's goal is, some of it is changing those incentives so the system works better for patients. So I've had this urge since the moment I realized value-based care had the potential to do great things for patients, for improving quality of care. But I really have this urge to help others in the healthcare professions, whether they be clinicians or those working in operations in healthcare, understand it better as an opportunity. Right now, a lot of the experts are policy folks, right? Or, those leading these programs, and that's great. And we need experts helping develop great policy. And there are some amazing geniuses doing this work. I would love to see clinicians understand it better so that they can take some of those learnings, advocate for them in their clinical care settings, right? Be a voice, just like any of us can be where we work, be a voice to say, we can do things differently. And there are new programs that, if we get involved in them, can allow us to provide better care, provide better transitions of care, whatever it might be. So that was my big kind of interest in doing this and writing a newsletter on my own.
Love it. Give us a sneak peek. What was that? It was a very recent one. What did it talk about? What'd you cover?
Well, I think one of my favorite ones I will talk about, because that's more interesting, is about the Medicare Care Choices model. So I have a particular interest in palliative care and hospice and home-based care, and this enormous opportunity we have to do better for patients with serious illness. So one day, I'll tell you a little story. I got this, evaluation of recent CMMI models, and in there, they have these, CMS puts these beautiful graphs together with greens and reds, and they show you it, or it's a simple table, and they tell you, okay, this is where this has been successful, this is where not. And the one program that had greens across the board, so utilization, readmissions, spend, yada, 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 was the Medicare Care Choices model. I had never heard of it, and I really think I'm pretty up on CMMI models, never heard of it. And so, talking to others, very few people have heard of it. So I'll tell your audience, it was an innovation center model. It's since ended, and it was a dual program for patients who met hospice criteria, but who did not want to stop treatment to start hospice. One of the qualifications right now for hospice is you end treatment for your terminal illness. And this allowed, although the payment was much, much lower than hospice payment, one of the choices a patient could make is to join the MCCM rather than join hospice, and move to hospice only when they decided to stop treating their serious illness. And what they found, although there was a lot of attrition because the payment for these services under MCCM was just, in my opinion, too low, and didn't cover the cost of sending social workers and nurses to the home to visit these patients, right? But it had enormous savings, lower acute hospitalization use, significantly lower spend, a much higher utilization of hospice. I mean, it couldn't have been better. It was glowing. And the unfortunate part was because of the attrition, when you look at the results of the model, they're relatively small, but they certainly speak to a potential we have not tapped, right? And actually, when I was at the last NACOS conference and I was on a panel with someone else, I went to listen to this through the Delaware Valley ACO. I was listening to their program that they developed through the flexibilities of the model they're in, essentially doing the same thing. They were providing an in-home palliative care service. And the numbers that they were showing, the savings for the ACO, the lower use of hospital, lower readmission risk was the same. It was through the roof. So I'm very excited about what we're going to see in innovation around managing patients with serious illness. There is a concurrent care for hospice beneficiaries as one of the flexibilities or beneficiary enhancements in ACO REACH. So we're seeing this thinking around and iterating on the idea of hospice has a really strict guideline around when a patient can be admitted. When might be the right time to add potentially a benefit that allows us to get patients moving towards hospice, right? Who are just not quite ready. And how does that impact the system? So I did a pretty lengthy newsletter, now blog, about that MCCM and what that potentially could mean down the line and how you can think about innovating in your whatever the space that you're in right now with the lessons learned from MCCM. Just to give you an example of that's the kind of thing I'd like to write about in my newsletter.
Yeah, I'd love to kind of double click on that and dig in a little bit more, because what do you think are some of those lessons learned? Do you think that the model was just happened to be a good use case, or is there some kind of underlying behavior, if you will, in a model that we can take and transfer over to some other models, as far as thinking between the lines of where, it sounds to me like what it did well, from literally hearing you talking about this for 30 seconds, what it sounds to me is that what it did well is maybe identifying an actual patient want, and that they didn't want this black or white choice. There was somewhere in between. What are your thoughts on some of the lessons?
Yeah, I would assume that it was developed because we know a great limitation of hospice is having the conversations with patients about ending treatment, and about the limited use case in hospice only in cases where you stop treating a disease. And so to reach, and I don't know what that percent is, but to reach patients who really truly are moving towards the end of life, they're in the later stages of their serious illness, and they may not just be quite ready to say, I'm going to stop treating, but that they would dramatically benefit from hospice services. A model like this, or if it's just a benefit that's eventually developed like this, would allow us to do better for our seriously ill patients. I love this whole concept because of my experience in working in transitions of care with seriously ill patients. It is for some patients, a very tough last year of life of circling the system, right? For patients who are just only going to get so stable and not be able to maintain that stability unless the focus is not on actively treating and exacerbating a condition that may be in the later stages and is harder to manage by continuously aggressively treating. We can help those patients have for those who choose it, a better end of life, or a better end of their serious illness moving towards end of life experience. You could define that a whole bunch of different ways. But if we had something that appreciated that sometimes patients, they may benefit from these great support services that may have an outsized benefit, besides the fact that they're not willing to stop treating. Because one of the things that MCCM found was a high percentage of patients, once they were on MCCM for a while, decided to opt into hospice. And that number of opting into hospice for MCCM patients was significantly higher than patients who had never been in MCCM. So it's to me, there's very clear lessons around this model and the, what we can take away from it. I just think that extrapolating that right now could be challenging because the size shrunk so much, which again, if you look and read my newsletter, if you're interested, but if you look at the numbers and the type of care that was being provided, the level of services, 2-3 times a week visits to the home by clinicians, it couldn't cover. It was about $400 a month. They could never cover the costs for that hospice to participate in MCCM ongoing. So very dedicated, right, innovative, the organization's able to stay in it. We're able to stay in it because they had a bigger perspective. They had other support. But, they did their best. It was a really well-designed model, but unfortunately, it's too low of a reimbursement for providing to just the last 6 months of life. Now, if that answers your question, I kind of winded around it.
Why did they end it? I'm just unclear about that.
Because it was an innovation center model. So it ended its natural end 5 years. Mm-hmm.
They sent it to hospice. Interesting. What's like a current model that you're most excited about?
Well, there's a couple that I find very interesting right now. We have I'm going to say most interesting, not most excited about. The dementia care model to me is very interesting. It's a no downside risk model, and the participants allowed to participate in this dementia care model are wide variety. So not just ACOs, not just primary care docs, but the center of these dementia care programs could be things like home care agencies, home health agencies, psychiatrists, neurologists. So, and a very high number of applications. They had to actually limit how many were accepted CMMI because it was more than expected.
Or is that a different one?
The guide model, the guide model. And so I'm really going to watch this carefully. The list has not been published yet, who the participants were that signed agreements, but knowing we're going to have this model and interesting also that it's a model that's doing a monthly payment, right? So for care management for dementia patients. And inside that payment is included a host of codes that provider cannot bill simultaneously with the dementia care bill. So if you're participating in Guide and you're billing that monthly G code, it'll be for dementia care, you can't bill an annual wellness visit, right? You can't bill for care coordination. Everything is encompassed in that one payment. So what I find interesting, and it'll be interesting to see if they got this right, will be in markets where you have ACOs that are not participating, that primary cares are doing annual wellness visits and doing, care management of their patients. And then we have a separate guide model and they're billing this monthly code that also is supposed to include the services that, are encompassed in a host of primary care services. What's going to happen, right? Are we going to end up with ACO attrition because the dementia patient is now building a relationship with a different provider who's seeing them for, or, potentially should or could be seeing them for a host of care coordination type of services? So it's a brand new territory. I love the fact as a PT that this is really thinking about caregiver training and supporting the family caregiver in the home. It's a remarkable step, but it will be interesting to see in a no downside risk model and with this overlap between that and every other model, what are going to be the downstream impacts? So, but that's why it's an innovation center model. It's being tested, and we're just going to all have to watch and see.
Fascinating. When does it kick off? In 2025?
Well, for established programs that were accepted because they already had an existing, they call it a DCP, a dementia care program, that starts this July. For the new participants, it's next July.
It's really interesting because I've always thought that, CMMI spitting out all these new models really dilutes the ability for any other model to be effective. And kind of what you just said, we're like, well, now you're going to maybe steal patients from the ACO, and the patients are going to have to choose allegiance, like who am I paying allegiance to? And then you're going to, you don't look so good. Well, I don't look so good because you stole my patients. But the truth is maybe that's the point. Is that what I'm hearing? That sometimes you want to put two dueling models into a market and kind of may the strongest win. Is that part of the theory or no?
It's hard to say. I mean, many stakeholders believe, and I'm speaking in those terms because I have opinions, and certainly you can hear them. But there's many things where we just don't know. So I don't like to be just so definitive. I feel this way or that way. There's plenty of concern that by adding a model that can live in the same environment as an ACO, where we can have one provider providing this one model and an ACO provider, and they could be providing the same types of services, even though one's billing under a G code, but that encompasses those services. There are questions as to whether it's best to do that outside of an ACO, or should we be allowing a model like that to be, added to, or as an option, as an example, to a total cost of care model. So we're not splitting off patients potentially. We're not losing patients from one to another. This does have the potential to drive more home-based care. So these dementia care programs can refer outpatient therapy to the home for home safety, right? They can recommend DME. They could, there's a provision and a once a year max payment for respite care. These are all things that are brand new innovations. We just don't know what the spend is going to end up looking like, right? What's going to happen? How close are patients going to get to the provider in charge of that dementia care program? And could that lead to a change in who they think is their accountable doctor? It could also do, one of the things we know CMS wants to do is 100% of patients in an accountable care relationship by 2030. This will bring in new patients and new physicians they're harder to keep as part of an attributed population, because with dementia, many of them, especially later stages, just stop going to the doctor. And we know they're admitted because they're not kept, partly because they're not kept close tabs on. And so the hope is that, and if we're being the most hopeful about this, the hope is that with the incentive to take better care and coordinate care and support these caregivers in the home, it will lead to what they hope will be reduced admissions and a delayed time period till a patient ends up in long-term care, or avoiding it altogether by doing this additional support. So it's going to be exciting to watch what happens over the years with this model.
We're about to kick off July. Fascinating. Wow. Well, Dana, we can go on for hours, as we sometimes do. But unfortunately, in the interest of time, really fascinating conversation. I really appreciate you spending time. Where can people, I highly recommend people check out on LinkedIn. Where else can people find you and your newsletter?
Yeah, it's just very simple, called timelessautonomy.com. You can sign up, and I'm sending newsletters periodically. I'm going to try to be sending shorter emails and just posting blogs here and there when I have something to deep dive on that's interesting to me. And yeah, I'd love for anyone to subscribe, and feel free to reply and comment, and love to start conversations, because that's how I think innovations happen, is people start talking and coming up with new ideas, and it gets others that are brand new exposed to this more involved.
Love it. Dana, thank you so much for spending time today. This was really a pleasure.
Thank you so much, Mendel.